A ventricular septal defect is a congenital heart condition that occurs because of a structural abnormality during fetal development that results in a hole in the wall between the two ventricles. Initially, the primitive fetal heart has only a single ventricle, but between 4 to 8 weeks gestation, the ventricular septum forms by muscular tissue growing up from the base of the ventricle and membranous tissue growing down. In the normal heart, the muscular septum and the membranous septum fuse together to form a complete ventricular septum. However, where the muscular and membranous septums fail to fuse, a gap is left in the septal wall, and this is a VSD. In the normal heart, oxygenated blood from the lungs returns to the left atrium, then goes into the left ventricle, and then is pumped out of the aorta to the body. Deoxygenated blood is returned to the right atrium via the inferior and superior vena cava, moves into the right ventricle, and then to the lungs for gaseous exchange. A VSD changes the circulation. As usual, oxygenated blood from the lungs returns to the left atrium, flows into the left ventricle, and then to the aorta to be delivered to the body. However, some oxygenated blood in the left ventricle will flow across the VSD into the right ventricle and then mix with the deoxygenated blood that's being sent to the lungs. Typically, there is a left to right shunt across the VSD because the higher pressure in the left ventricle pushes blood towards the lower pressure in the right ventricle. Consequently, there is increased blood flow to the right ventricle and therefore increased blood supply to the lungs. This results in increased vascular pressures within the lungs, with excess vascular fluid being pushed out into the alveoli, causing pulmonary edema, which can result in difficulty in breathing. Sustained increased pulmonary pressures or pulmonary hypertension will lead to pulmonary vascular remodeling. Due to the increased pulmonary blood flow, higher pressures are exerted on the pulmonary artery walls, and over time, the vessels will become increasingly muscular and inflamed, resulting in luminal narrowing and consequently higher pulmonary pressures. Higher pulmonary pressures means that the right ventricle has to work harder to pump blood to the lungs, and as a result, the right ventricle will become bigger and more muscular, resulting in right ventricular hypertrophy. Right ventricular hypertrophy can make the right ventricle less efficient at contracting, and heart failure can develop. Eventually, the pulmonary hypertension can become so severe that the high pressures start to force deoxygenated blood backwards into the right ventricle, leading to a reversal in the direction of the shunt. This is Eisenmenger syndrome. Deoxygenated blood shunts from the right ventricle into the left ventricle and then into the aorta and then out to the body. This results in tissue hypoxia and ischemia, and as the body tries to compensate by producing more red blood cells, hyperviscosity develops, increasing the risk of blood clots and stroke.